Today is lecture 7, Tobacco, on nicotine and related disorders. Today's topic is very unique. Unique in the sense that on one side you get a lot of patients of this in private practice and less of these in government setups. And secondly, this patient is much more in OPD than indoor. So I have seen some of the departments in psychiatry where the residents are mostly in the management of indoor patients. I'm not blaming any department or not naming here, but what I've seen is I've seen a medical college where psychiatry department OPD was managed by consultants. When the patient got admitted, the indoor patients were managed by the residents, and all the discussions, academic discussions, were on the indoor patient. So I met a second year resident on there. So he didn't see GAD case because GAD patient came to the OPD discharged by the professor. So tobacco, again, it is a patient. In my 3 years of residency, I have not admitted any patient for tobacco. Have you ever admitted any patient for tobacco de-addiction? Can you tell me, tobacco de-addiction, do the patient need hospitalization? Is tobacco de-addiction hospitalization needed? Are there some residents who have never ever managed a nicotine dependence independently? Don't be, feel bad about it, because I've seen many residents don't manage nicotine dependence independently because nicotine dependence comes in the OPD, goes away. And many of the setups, it don't even come because nicotine dependence patients are less treatment seekers. Can you tell me why? Why are they less treatment seekers? Because nicotine related behavioral problems are very limited to the extent of absent, unlike alcohol related behavioral problems, which are much more, cocaine, amphetamine, cannabis related behavioral problems, which are much more. This I am not speaking from any book, this I am speaking from my experience. Do you agree to me? Dr. Rekha, you already completed MD. Other students who are in MD third year or MD second year, have you seen nicotine dependence patient coming to you, admit me for smoking cessation? Do you people get me why I am framing this background? I have kept 4 hours for tobacco, alcohol, 2 hours for opium, 2 hours for cannabis. If you open the textbook about nicotine dependence, it is hardly 4 pages in synopsis, 8 pages in your CTP, and yesterday I was reading Lowenstein, it was around 15 pages. So tobacco dependence is the smallest chapter, but do you think the magnitude of the problem is small? No. The magnitude of the problem is more. Most common substance use is tobacco, but most common substance use in treatment seekers is alcohol. Do you agree? Then the second reason why less treatment seekers is it has a relatively less severe withdrawal. We have seen in the withdrawal, of alcohol, patient gets seizures, delirium. We have seen in withdrawal of opium, patient gets severe muscle cramps. Do we get such severe thing? And third, last but not the least, even forced dependence, forced de-addiction is not there. Like in alcoholic, family members push. In nicotine, family member not push. Relatively, a socially acceptable form of dependence. Do you agree? This is highly controversial. Highly controversial. We say that caffeine dependence is completely socially acceptable dependence. Alcohol dependence, social drinking, a little acceptable. But don't you think that amount of nicotine smokers we have in and around us, gradually it is a kind of relatively socially acceptable dependence? Yes. I've taken a lecture on this. I have said in general public, I was taking a lecture with Delhi police people. So I said to them, there are more number of smokers than drinkers. But to me, more number of drinkers reach than smokers. When I ask them, do you also smoke? Most of the time they say yes, because both dependence sometimes are together. There are few smokers who say we only smoke when we drink. There are few drinkers who say we only drink when we smoke. So some kind of comorbid dependence is also there, combined dependence. Then moreover, it is a relatively socially acceptable dependence, because if somebody drinks, we find him more at fault rather than somebody smokes. Do you agree? And nicotine is a illicit substance, not an illicit substance, just like cannabis. Smoking in public place is crime, but not otherwise. But cocaine, amphetamine, they come in NDPS, they are otherwise also crime. Do you understand me? Are you getting the whole scenario? Because I tell you, I have done MD from Government Guwahati Medical College. In 3 years, let's say I saw average, let's say 30-40 patients of nicotine dependence, because we had, let's say, once a week OPD in which 2-3 patients come or whatever. But independent, only nicotine dependence, only coming for de-addiction. But once I started my private practice, first I started in Udaipur, Rajasthan, then I moved on to Delhi. In Delhi, I am seeing these patients very often. And you cannot just tell them Nicotex. Every person in this world who smokes nicotine is aware about the Nicotex. Are you aware what is Nicotex? Nicotex is nicotine gums. And nicotine gums are available at the same place where cigarette shop is there. In Maharashtra we used to call pan dukan. पान की शॉप पे जहां पर सिगरेट मिलता है वहीं पर निकोटेक्स मिलता है. इनफैक्ट द लोकल वेंडर्स, दे आर ओनली डिस्पेंसिंग. ओके, आज सिगरेट लेने का मन नहीं है, आज निकोटेक्स चबा लो. आज निकोटेक्स चबाने का मन नहीं है, आज फूक लो. इज दिस द मीनिंग ऑफ निकोटीन रिप्लेसमेंट थेरेपी? This is the level to which nicotine replacement therapy has drooped, because nicotine replacement therapy is an excellent therapy for tobacco dependence and it is being misused. Have you seen TV commercial about nicotine, Nicotex? I'm talking to you. Are you getting the background of this? Today what I'm going to teach you is not going to help you too much in the theory exam. It is possible that some professor may ask you some viva question, but what I am going to teach you is going to help you in private practice, if at all you start your independent practice. Because what I have seen in even de-addiction centers, they are not nicotine focused. I referred a patient of nicotine dependence to de-addiction center. When he went there, he said, "Sir, why have you sent me there? There were all alcohol, opium, cocaine. What I am supposed to do?" Technically, nicotine also needs rehabilitation. But when I sent him there, out of 100 patients in that rehab, he was the only nicotine person. Do you agree? So this is a patient who is to be managed by you all alone in independent private practice. This is a patient who is to be given pharmacotherapy, nicotine replacement therapy and psychotherapy, basics of dependence counseling by you. Do you get me? At least respond yes, no. I am framing the background of today's lecture. Do you understand? Because I don't want to teach everything from the textbook. There is something should be coming from my experiences. Do you get the background? Come on, at least say yes, no. Hospitalization is not needed unless comorbidity or polysubstance use. Do you get the background? We will discuss nicotine under the headings of acute effects, side effects, overdose or toxicity, withdrawal and the management of withdrawal, the de-addiction of nicotine, mainly nicotine replacement therapy, non-nicotine drugs. In non-nicotine drugs, we have varenicline and bupropion. If you ask me, a theory question on nicotine has come on a drug and nicotine replacement therapy. Your Viva may ask about nicotine withdrawal. When I teach you any substance headings, I always make common type of headings, whether I have taught you alcohol, opium or cannabis. Do you see something unusual in nicotine headings? Is there anything that's missing out here that was there in alcohol, opium and cannabis, which is missing out in tobacco or nicotine? Any heading that is absent here? Are you making these notes? Please make these notes properly. Today I have incorporated notes of many areas and I want to discuss. There are a lot of things in my mind to tell you today. Because initially when I reached Delhi, I wrote to a patient Champix. Champix is varenicline and it was not even available easily. I don't know what's the issue with Delhi, because Delhi is such a big place. When I was practicing in East Delhi, the psychiatry medicines are only available in and around Ibas. Any resident for Ibas here? I was practicing in Metro Hospital Preetviar, so the patient had to go to Dilshad Garden to buy the medicines. They are not available routinely with every pharmacy. They are available only where our psychiatry people are sitting. But this was not true when I was in Guwahati or Udaipur. They were available in routine pharmacy. I don't know what is the issue with Delhi, but I have found great problems in arranging medicines for my patients sometimes. Is Champix easily available in your place? Champix. It is the only varenicline that is available.